So I'm going to take us quickly first through what we're going to try to accomplish and then explain the format. And so the title today is the lipid panel, clinical pearls. And we're literally going to go through a basic lipid panel and to give you the ability to look at it with expert insights and to make decisions off every single piece of information there, things you're probably looking at right now and not necessarily acting on. So our objectives are to help you increase the understanding of the current best practices for the interpretation of a standard lipid profile, apply that profile for optimization of statin and non-statin therapies, and use other risk markers to further mitigate residual cardiovascular risk. So I want you to adopt this learning mindset. Right now, you're sitting in the clinic and you're seeing a patient in whom you've obtained a standard lipid profile, simple total cholesterol, an LDL, an HDL, a non-HDL, and triglycerides. I'll bet when you look at that and you get that, you see the LDL and you don't see much else, if you're like most of us. So the question is, how do you approach these numbers to make diagnostic and management decisions? And are you using all that information as well as you could? Simple task today. So we're going to review each element of the standard lipid profile with a short clinical vignette and then some thoughts, our expert thoughts on what Ori and I do to think about the pathophysiology and the management of that particular result. We're going to talk about LDL. We're going to ham and egg it a little bit. Ham and egg, you take a bite of one and take a bite of another and you go back. Okay, so I'm the ham and Ori's the egg. Ori's going to start with LDL. I'm going to touch on HDL. Ori's going to go to non-HDL, and then I'm going to follow up with triglycerides and then CRP. And my big, hairy, audacious goal for your next hour of your life is to, after you leave this, say, that was the best damn lipid lecture I've ever heard because it helped me take care of patients and I have better preventive cardiology skills. So it's a real pleasure to introduce Ori. Ori is the only lipid-trained expert in the entire MedStar health system. He's a spectacular second-year fellow, as all our fellows are, but he did his med school in Israel, trained in the Sinai system in the Bronx, and then spent a year in a lipid prevention fellowship. So he's actually board eligible for the lipid boards, and we don't have anybody else like that in our entire system, including me. I'll give myself constructive credit for having done this for 35 years, but Ori is actually the authority. So we've had a good time making this talk together. We've had a lot of nice discussions. So with that introduction, we're super proud of Ori. Ori, you do see the last name Waksman, and yes, indeed, Ron Waksman is his father. So that puts Ori on top, but Ori's on top of the pile today for prevention. And Ori is interested in interventional cardiology, which I think is perfect because there's no better match between treating with interventional cardiology, but also having a prevention mindset. So Ori, thanks for doing this and agreeing to do this. Take it away, buddy.
Thank you very much, Dr. Taylor. Thank you very much, Georgetown Department of Medicine, for inviting us. Very excited to share a little bit of our insights. What we're going to do is discuss a few cases together, talk about our thought process and what our clinical decision points are going to be. So let's go into our first case. See this guy in the clinic come in. He's a 68-year-old gentleman, has a history of hypertension, CKD, and coronary disease. In 2021, had some chest pain, went for a cath. They found an obstructive lesion, underwent a PCI Tismid LAD. He completed a year of DAPT and is following up to see you. Hasn't seen anyone since. Feels well, has no exertional complaints. Labs are normal. These are his medications, and his lipid panel is as follows. And what are our next steps? And so the first thing when I see a patient is I really want to identify what his LDL cholesterol goal is going to be. And this is where we can get into the guidelines. The guidelines obviously are readily available online. And there's two big problems with the American guidelines as they stand. One is that they're very conservative compared to our European counterparts in the ESC. In terms of LDL goals, we really just don't drive home the point that lower is better. The second, and it's more of a concern for a trainee or the internist, is when you look at the guidelines, they're very convoluted. There's a lot of flow charts, if then this, but if then that. So you'll see very high risk, moderate risk with an event, risk without an event. And sometimes following these flow charts can just be a little bit overwhelming. So through my training at the Mount Sinai system, working under Dr. Robert Rosenson, who's a professor of lipidology there, we've kind of come up with this algorithm. It's not really per the guidelines, and so that's my caveat, but it's a very simplified way of looking at LDL cholesterol goals for any patient that comes in. So I divide patients into four groups when I see them in the clinic. The first group or category of patient is anybody with any sort of coronary disease. And I mean any. I mean a coronary calcium score of 1. This category encompasses patients who've also had MIs, secondary prevention, etc. Anybody with evidence of coronary disease, the atherosclerotic process has started, and we need to be aggressive. Aggressive for me means lowering to an LDL cholesterol of less than 70 and ideally less than 55. The second group of patients I'm extremely aggressive with is anybody with an untreated LDL cholesterol above 190 milligrams per deciliter. That number isn't random. It's pathognomonic usually for familial hypercholesterolemia. Familial hypercholesterolemia is an autosomal dominant inherited gene in which you just don't clear your cholesterol. Your efflux is reduced. As a result, these patients tend to have 30 times the amount of cardiac events than non-FH patients. Patients with an untreated LDL of 190 all the way to the 300s usually have HeFH, heterozygous, with LDL levels above 400 conferring more of the homozygous variant. Anybody with this sort of lipid panel, I quickly launch an investigation for FH. I look for clinical signs, corneal arcus, cholesterol deposits in the corneas, tendon xanthomas along the dorsum and the Achilles tendon, family history, and I treat aggressively. Again, my LDL goal here is 70, ideally less than 55. Next category is diabetics. We all know the vascular complications of diabetes, and these are not patients I'm shy about treating. Again, the guidelines really don't mention a goal of 55. I'll say I wrote down 70 for higher risk patients, but really, again, I drive the lower the better, 70 and at least 55. Everybody else who doesn't fall in this category kind of goes into the pile of the ASCVD risk calculator, which is based on the Framingham study. Per the guidelines, the ASCVD risk calculator, patients with a risk of 7.5 up to, I think, 15, our LDL cholesterol goal is 100. And then if they have more risk enhancers, then we try to be more aggressive. The problem with the ASCVD risk calculator is it leaves a lot on the table. It doesn't incorporate race. So we all know Southern Asian heritage is a big risk factor. It doesn't incorporate inflammatory conditions. It doesn't incorporate chronic infectious states like HIV. And it doesn't incorporate elevated lipoprotein A, all of which are huge risk enhancers that get omitted by this ACVD risk calculator. So again, anybody who you see who doesn't fall in those three categories, plug them into the ACVD risk calculator and take into account some risk enhancers that they may be. Before getting into the patient and management, I'm going to sidebar even further and talk about four philosophies I have when I treat cholesterol. And these are my mantras of LDL lowering. One is the lower the better. Two is we can actually shrink the plaque if we're aggressive enough. Three is this is really a disease that goes with you your whole life. It doesn't start at the age of 40, 50, where it becomes known. It's really a cumulative lifetime burden. And atherosclerosis is not just cholesterol, it's cholesterol plus inflammation. And these are partners that cause a disease. And so let me touch a little bit on each point and we'll get back to our patient. So when I say the lower the better, I always like to give a tangible target of what that means. Let's say we have a patient with an LDL cholesterol of 160. For every 40 milligrams per deciliter that we reduce the LDL cholesterol, we reduce the risk of mortality by 20%. That means if you take somebody with an LDL cholesterol of 160, you treat them with a statin and you lower their cholesterol to 80 milligrams per deciliter, you've reduced effectively the risk of cardiac mortality by nearly 50%. Take that a step further. Let's say 80 is not a crazy number for LDL cholesterol, but let's say you drive them down more so. You augment their therapy and you reduce their LDL cholesterol to 40. That 20% residual risk reduction is proportionate. So you've now reduced their risk by another 20%, meaning it doesn't matter how much you reduce the cholesterol based on the baseline. As long as you're reducing, there's a reduction in risk. And this is linear across all levels. There hasn't been a cholesterol level demonstrated by any studies, observational or otherwise, in which the risk reduction plateaus. The question you might ask is, let's say I've aggressively treated patients and now their LDL cholesterol level is a number that looks scary to me. Let's say 40, LDL cholesterol of 20, 10. That doesn't seem physiologic. I'm not used to seeing those numbers. And a lot of observational post hoc analyses have looked at these studies and looked for adverse safety events. One of them is the 4-year trial, which was a PCSK9 inhibitor trial evaluating the safety of evolocumab. And what they did is they took a subgroup of patients and looked at if there were any increased adverse events, cognitive, myopathy, otherwise, when you drop their LDL cholesterol to very low levels, defined as less than 20. And there were no statistically significant adverse events, even at these very low LDL cholesterol levels. So as far as we're concerned in the cardiology community, the lower the better. There's no evidence to suggest any adverse safety events at lower cholesterol or lack of benefit at a certain LDL cholesterol level. The next point I want to bring up is, where do these numbers of 55, 70 come from? They seem a little bit arbitrary. And a lot of it comes from data in which they really try to see at what point you reduce the LDL cholesterol enough to get the plaque to shrink. And a lot of these studies, what they did was they took patients, did IVUS, which is ultrasound of the coronaries, measured their cholesterol and plaque volume, started them on a therapy, and you have several studies here, and then came back several months later, years later, to measure the atheroma volume after intervention. And what you really see is that once you start consistently dropping the LDL cholesterol below 70, you start seeing a regression in plaque volume. And the R squared for this association is nearly 1, so very closely associated. Conversely, if you start having LDL cholesterol levels that are uncontrolled, then the plaque starts to accumulate. So getting patients below 70 means that the plaque is going to be neutral. The lower you drive it below, the more we expect the plaque to regress. Of course, you're never going to have 100% regression. Calcium isn't going to go away, and the effects of 40s, 50s, 60 years aren't going to disappear overnight. But you can stabilize the plaque and definitely shrink its volume with aggressive LDL lowering. 2 more points. When we talk about LDL cholesterol, I want you to think about a lifetime disease. You can have patients who come to the clinic who don't fall into the ASCVD risk category because they're 35, they're 36, but they have high cholesterol. And I want to introduce to you the Cardia study. The Cardia study was a prospective study of about 5,000 adult males aged 80 to 30, where they really followed them longitudinally for a long time. I think they revisited them back in 2017, looked at multiple markers. But one thing they did for them was calculate their LDL cumulative burden, which is kind of like our pack year smoking assessment for smokers. So they saw how much cholesterol, how elevated their LDL-C was, and how long they carried that burden for. They took that all the way to the age of 40 and then followed them afterwards to see if there were any cardiac events. What they found is that the patients with the highest cholesterol burden below the age of 40, even with interventions, i.e. statin, if they changed their lifestyle, whatever they did after the age of 40, having that high cholesterol level for 40 years put them at an increased risk of cardiac events, meaning that sometimes it's too little too late to start treating cholesterol in our 50s, and we really accumulate a lot of subclinical disease for those ages 0 to 40. And so treating patients at a younger age is certainly encouraged. The last point, and Dr. Taylor will talk about this more towards the end of our talk, is that atherosclerosis is not just cholesterol. It's cholesterol plus inflammation. There's 2 landmark studies that illustrate this beautifully. I'll talk about them briefly. One is the Jupiter trial. Jupiter trial took patients who had elevated CRP, but no indication for cholesterol lowering. They didn't have hypercholesterolemia per se. They gave them rosuvastatin. And what they found that rosuvastatin not only drove their CRP, but when adjusted for LDL cholesterol, also drove down their cardiovascular events. Meaning that, one, and I'll talk about this in a moment, statins had pleiotropic anti-inflammatory effects, but 2, even when you corrected for the lipid lowering, reduction of CRP reduced cardiac events. Similarly, the CANTOS trial, use of a monoclonal antibody that neutralized interleukin-1 but had no effects on cholesterol, lowered the amount of cardiovascular events in patients with prior MI. You drive down inflammation, you drive down residual risk. There's more data to come, and I'll leave that up to Dr. Taylor. But let's get back to our patient. So our LDL cholesterol is 202. He has a history of coronary disease. He has CKD. He's hypertensive. He's getting up there in age. This is a guy we want to be aggressive about. Next question is, what are our therapeutic options? What are the tools in our chest? So let's start with statins, and I'll give you a rundown of my thought process of statin selection. Statins, we know the mechanism, HMG-CoA reductase inhibition. What that means is that it reduces the synthesis of cholesterol and increases the expression of hepatic LDL receptors to enhance the clearance of cholesterol from the serum. With certain doses of the medication, rosuvastatin particularly, you can have an LDL reduction of up to 55 to 60%. The advantages to this therapy are robust outcomes data, great safety profile, and pleiotropic anti-inflammatory effects like we cited in the Jupiter trial. It's these anti-inflammatory effects that is the reason why in the setting of ACS, sometimes you'll consult the cardiology service, will tell you put in a statin. We're not all of a sudden concerned about primary prevention or secondary prevention. We're trying to stabilize the plaque. The disadvantages are the rare but recognized adverse events, and these really come as a big, psychological burden to a lot of patients and clinicians. The incidence is pretty easy to remember. You'll have an LFT elevation in 1 in 100 patients, myopathy in 1 in 1,000, rhabdo in 1 in 10,000, and drug-induced liver toxicity in about 1 in 100,000. So overall, the safety profile is safe, but these are the known adverse events. In terms of just addressing these really briefly, transaminase elevation, my criteria to stop a statin is 3 times the upper limit of normal. In terms of myopathy, I always recheck because the CPK might be elevated due to adverse events. I always make sure as well that it's bilateral proximal upper and lower muscle weakness and not some other myopathy. And I trial cessation of therapy for resolution and improvement. When we're prescribing statins, these are some of the agents we have available to us: torvastatin, simvastatin, rosuvastatin, pravastatin, lovastatin. There's also pitavastatin, fluvastatin, other older agents. What I want you to notice is there's really a sigmoidal dose response. So you can double the dose of a torvastatin or from 40 to 80 or rosuvastatin from 20 to 40, but you're not going to get a doubling in effect. You'll get maybe another 10% reduction. What you will get is a doubling in the risk of side effects. So it's important to know that there's a sigmoidal dose effect of these medication. The second thing I want you to notice is that there's 2 statins that tend to overperform the others, and that's atorvastatin and rosuvastatin, which confer much more aggressive lipid-lowering therapy than the others. These are our high-intensity statins, meaning they reduce cholesterol by greater than 50%. When we think about statins, here are some other considerations. For rosuvastatin and atorvastatin, the half-life is 17 to 20 hours. These are long-acting agents. Older agents like simvastatin, pitavastatin, lovastatin, these were very short-acting agents that were given at night, usually because nighttime is when cholesterol synthesis takes place. That's why there's that nomenclature of giving a statin QHS. With atorvastatin or rosuvastatin, that really doesn't matter. These are long-acting medications. The other 2 things to know about these medications is rosuvastatin is renally cleared in part, and so there's always considerations. If the patient has CKD or renal insufficiency, you might want to defer to atorvastatin. Atorvastatin, on the other hand, is metabolized through cytochrome C450 pathway. And so a lot of those drug-to-drug interactions in a patient with polypharmacy, a patient who's on amiodarone, antibiotics, is insistent on drinking grapefruit juice for whatever reason, those become an issue with atorvastatin. Again, if somebody has an adverse effect, myopathies, you can always look at how the statin is metabolized, try to reduce the dose, and switch to a different agent. But those are my pearls about rosuvastatin and atorvastatin. That's why I select these 2, not only because they're the profound lipid-lowering agents, I have more, I can refine them better for my patient. Another drug therapy that we routinely see is ezetimibe. Ezetimibe is a medication that simply works by inhibiting the absorption of cholesterol in the small intestine. It has a very mild LDL cholesterol lowering effect, 15 to 18%. Studies have suggested improved mortality and improved outcomes. There's the IMPROVE trial, which took simvastatin, again, not an optimal statin, and added ezetimibe to it. With reduction of LDL cholesterol, there was reduction in mortality and events. Is this due to overall LDL cholesterol lowering or something with ezetimibe? Hard to tell. The biggest disadvantage is that the residual risk reduction with ezetimibe is minimal. And unlike statins, there's no anti-inflammatory benefit. Another agent that we see a lot of is, and it's a little bit cut off, are the PCSK9 inhibitors, which are evolocumab and alirocumab. Briefly, just to understand the mechanism, we talked about LDL receptors clearing cholesterol from the serum through the liver. You have an enzyme called PCSK9. The job of PCSK9 is to degrade the LDL receptor. When you degrade the LDL receptor, you obviously reduce cholesterol efflux out of the system. If you inhibit PCSK9, inhibit this enzyme, you get more LDL receptors on the liver, you get greater clearance of cholesterol. These are very potent agents. Repatha, evolocumab, can reduce LDL by 64% on top of statin. Alirocumab, a little less potent, 58%. These are sub-Q injections taken every 2 weeks. You also have monthly dosing, which is less potent. Good outcome study in the Odyssey and Fourier trials, which investigated the safety and efficacy of these drugs. They also lower Lp(a), which is a little bit off-label. Because they are a monoclonal antibody, you don't have the systemic effects of the statin medications. Downsides, they are cost prohibitive and no anti-inflammatory benefits to date, no reduction in CRP with these agents. Another exciting medication, which we got promising news about earlier this year, is bempedoic acid. Bempedoic acid, the mechanism is inhibition of ATP citrate lyase. Ignore all that. Take a look at this chart. It's the same pathway as the statin, just one step up. It's a great medication for patients who are statin intolerant, and it can reduce LDL cholesterol by 18% as monotherapy. When you take it with a statin, that number jumps up to 25 to 30%. The CLEAR trial represented that bempedoic acid was associated with a reduction in cardiovascular events in statin-intolerant patients. It reduced CRP, so statins and bempedoic acids are the only agents we have with CRP reductions, and there was no muscle crossover, so no myopathy, no exacerbation of those effects we saw with statins. Disadvantages, cost, it's improving, and then the reduction of LDL is modest. But this is another great agent. So one more, I forgot I had this slide. This is inclisiran, similar to PCSK9, same sort of idea. We're going to inhibit the PCSK9, but we're not going to do it through a monoclonal antibody. We're going to do it through siRNA targeting. The biggest benefits to inclisiran, and it'll arrive at Georgetown Hospital Center soon, I hope, is that it reduces LDL cholesterol by a good amount, 40 to 52% on top of statin therapy. And then the dosing is infrequent. You take this medication twice yearly, 3 times the first year, then twice thereafter. It is a big volume, about 50 to 100 cc's, so it has to be administered in the clinic. But this is great for patients who have issues with needles or are non-compliant. You can just bring them in once or twice a year and really tackle their cholesterol. Seeing how much the LDL reduction really affects mortality kind of drives this point home. So getting to our patient, finally. He had a cholesterol of 202. I picked rosuvastatin 40 or atorvastatin 80. I could have easily done 20 and 40 and seen his response. I maxed him out, and we got his LDL down to 110. At that point, I wanted to give him another oral agent before trying evolocumab. I could have done ezetimibe or bempedoic acid. I chose bempedoic acid, good synergenic effects. I was able to lower his cholesterol even more so by 25 to 30%, down to 80. Then I wasn't at goal. Again, we discussed his goal was 55. I'm really trying to drive this guy down. So then I decided to prescribe a PCSK9. At that point, we get him down to 32. He's at goal. And then I've effectively mitigated the cholesterol part of his cardiovascular risk. So I'll hand it over to you, Dr. Taylor.
Thanks, Ori.
Sure.
Thanks, Ori. Yeah, I would say that I use pretty much rosuvastatin almost exclusively these days because it is the most potent statin, and 55 is the new 70. And so to get there, everyone hearing this now is going to have to commit to knowing how to and using these secondary medications. Is just as we use more than one drug for hypertension and diabetes, we have to do this for lipids. So my next task is to bring you through another case, and we're going to talk about HDL. So imagine a 60-year-old delightful male patient who had an inferior STEMI 5 years ago. He always rebels me with his trips to Wisconsin and the cheese he eats up there, but he says he only does that in the week he's up in Wisconsin. He's had no intervalencer problems, and he is asymptomatic from an LVH, from a cardiovascular standpoint. His EF is normal. He is on atorva 80, he's on clopidogrel 75. This is his annual lipid profile. His total cholesterol is 134, his HDL is 36, his LDL is 80, and his triglycerides are 129. So applying what Ori just went through, you're going to say, well, that number is not 70, nor is it 55. So we're going to have to do something here. But the number that stands out to me, in addition to that, is this one. And I bet as most of you are looking at this, you're saying, well, I don't really know what to do about HDL these days, because you're right. I don't have a specific therapy to give you that treats HDL. A decade or two of research to try to do that led to nowhere. So I think your typical response would be, I don't look at the HDL because I don't know how to treat it. It worries me, but I don't know what to do. And I ask you the question, would you change any decisions? And I'm going to show you how to do this. I use HDL to deliver personalized care about lipid goals. So a few points of knowledge on HDL. The first thing is the guidelines are relatively mute on HDL because they look at evidence on clinical trials and there aren't therapeutic options. But I don't necessarily endorse that situation. To do this, you've got to know what is low. And low is relative, as I'm going to show you. Just like the Framingham study showed us decades ago, that at any given level of LDL, lower HDL portends higher risk. And there's an interaction here that your risk is lowest when your LDL is low and your HDL is high, and your risk is highest when your LDL is high and your HDL is low. Now, HDL's primary function is to be assembled from proteins secreted by the hepatocyte that circulate and collect cholesterol in the periphery and transport them back to the liver. We call that reverse cholesterol transport. HDL is also one of the most powerful antioxidant particles in your bloodstream through a thing called peroxidase. And peroxidase circulates on HDL and it protects your lipids from being oxidized. But as soon as HDL is dysfunctional and peroxidase activity deteriorates, HDL turns inflammatory. LDL is oxidized, and HDL is directly inflammatory to your vessel wall. And you don't know when that's the case because you can't measure the inflammatory activity of HDL. So it's not just concentration, it's the quality of HDL. So these two functions, efflux of cholesterol and antioxidants, are the two things that make me worry when HDL is low because those things aren't happening. So I look at HDL relative to LDL. I'm going to make that point to you in 2 data points. This top right comes from the InnerHeart study. InnerHeart was a study of all risk factors for cardiovascular disease and what the population attributable risk is. And what it showed is that the population attributable risk from all cardiovascular risk factors is the highest for lipids. Exercise, blood pressure, diabetes, all important, but not as impactful as lipids. But in the InnerHeart study, the lipids measurement was not LDL. It was not total cholesterol. It was the ratio of LDL to HDL. This is the ApoB to ApoA1 ratio. Now that basically ApoB, as Ori's going to show you in a bit, is that's the lipoprotein, that's the protein on the lipid surface that marks a particle as a atherogenic particle, and it's a family of particles. Anything with an A, ApoA, is HDL. So this is in effect your LDL HDL or your non-HDL HDL ratio. So this ratio is the highest when either LDL is really high or HDL is really low. And this ratio is lowest when LDL is low and this HDL is high. That's the ratio here. And you can see that the odds ratio for events is the lowest when this ratio is the lowest. And it's a direct linear correlation. And you can get to this, you can get up here at high risk by one of 2 ways, high LDL or low HDL. When I see a patient that's been treated in the clinic with an LDL of 70, and they say, doing great at goal, and the HDL is 20, that patient is on fire inside. It's absolutely on fire. Here's more data. This is on regression of atherosclerosis. Ori said the mantra, atherosclerosis can regress. Indeed, it can. This is percent change in atheroma volume based on, and anything above this line would be progression. Anything below this line would be regression. And the horizontal lines would be stable atherosclerosis measured inside a coronary artery using intravascular ultrasound. So you can see at an LDL above 70, people progress. So 70 sounds like a pretty good goal, except the lower your HDL, the lower your HDL, the more you progress. And when you look at the ratio of LDL to HDL, and that's what this is. And again, this is all progression. If your LDL to HDL ratio is over 1.5, you are progressing. And only when your LDL HDL ratio is 1, your LDL equals your HDL, can you look at a patient confidently in the eye and say, I've stabilized your problem. So think of that LDL 70 HDL 20 patient, that ratio is 3.5. They are on fire and they are progressing even though their LDL looks controlled. So you want your LDL to equal your HDL, and you don't want it any more than 1.5 times your HDL. So I can't tell you how to raise HDL, but I can tell you how to lower LDL. And that's the magic bullet here. You've got to select personal LDL targets to get the ratio below 1.5 and optimally to 1. Here's data from a trial that proves this point. This is the Treat to New Targets trial. At lower levels of HDL, risk is higher. And this is all patients on either atorvastatin or 80. This is an RCT of atorvastatin versus 80. You can see that at low levels of HDL, if you're on atorvastatin and your HDL is low, doesn't matter what your LDL is, you do better if you uptitrate the statin. Atorva 80 is better than atorvastatin, only really at low HDL levels. Even if your LDL level is below 70, at low HDL levels in the bottom two quintiles, you're at higher risk. And only when your LDL HDL ratio is less than 1.33 are you at optimal risk. It doesn't matter whether an atorvastatin or atorva 80. It doesn't matter what your LDL level is. If that ratio is anywhere above between 1 and 1.5, you are at higher risk. So I don't use LDL targets. Those are population goals. Those are people that write guidelines, but that's for guidelines. I use what your LDL is and what your HDL is, and that determines your LDL goal. If your LDL is 20, if your HDL is 20, your LDL goal is 20. If your HDL is 30, your LDL goal is 30. And that's how I practice. The other thing I do is I recommend dietary change for HDL. So we're getting back to the inflammatory component. You can't change the inflammatory component with drugs, but you can with diet. Anthocyanins are the blue and dark pigments found in berries like raspberries, blueberries, bilberries, blueberries, and blackberries, pomegranates. And these are water-soluble pigments, but they are also phenolic flavonoids, and they are strongly antioxidant. And trials show that dietary supplementation with anthocyanin-rich fruits actually improves the efflux of the HDL-driven efflux of cholesterol from macrophages and is directly antioxidant and preserves the peroxidase activity of HDL. And these are the data that basically that show those changes. For example, this is efflux. If people were treated with anthocyanin, they had significant efflux from cholesterol from macrophages, where placebo they did not. So I will recommend not just fruits and vegetables, but very specifically dark berries for people with low HDL. So back to this patient. HDL to me is, I think, a huge missed opportunity for us, and I use it very strongly to influence the way I practice around LDL. So my response to this lipid profile by this patient was to integrate the HDL and do his LDL and risk management. For his LDL, I said, but guidelines say it's greater than 55, so the first thing I'm going to do is flip him to rosuvastatin. Atorva 80 is a good drug, but rosuva 40 is better, and I might as well not leave anything on the statin cutting room floor. But I'm going to personalize his LDL goal. His LDL goal for me is 36. And that's to get to this ratio of 1 to 1.5. I need a 60% reduction in LDL from 80 to 36. And that's a PCSK9 inhibitor. Only way to go here. Can't mess around with ezetimibe. You can't mess around with bempedoic acid. You just got to go to a PCSK9 inhibitor. And then it's daily anthocyanin-rich dark foods, daily. So, buy some blueberries and have at it. Okay, so I hope that gives you an impassioned plea on thinking about HDL a little bit differently. And it's all through better management of LDL and some simple dietary intervention. But if there's LDL and there's HDL, and then there's the rest, which is called non-HDL. And it's everything else in your lipid profile that's got an ApoB. And Ori's going to take us through the ideas around non-HDL cholesterol.
Thanks again, Dr. Taylor. So let's present a different case. We talked about the agents we can use to lower cholesterol, but not every patient wants to be on medications. Not every patient is eager to start something new. So in our clinic walks a lovely 52-year-old woman. She is here just for routine follow-up. In 2020, we did a coronary calcium score, which showed 0. Her lipid panel is as follows: LDL cholesterol of 115, not ideal; triglycerides of 90, HDL of 41. You calculate her ASCVD risk score, and I really just picked a random number. You can make it 5.5, 4.5, 7.5. It's mild. Her lifetime risk is elevated. She's not keen on starting medications. So the question is there any other ways to just, if we're looking at LDL cholesterol alone, to stratify her risk? Meaning, is her LDL cholesterol something to worry about? And we have two modalities to better delineate the quote unquote atherogenicity or toxicity of the LDL cholesterol. And the first one is going to be the LDL particle number. So like Dr. Taylor mentioned, every atherogenic lipoprotein, and what that means is every lipoprotein that has the ability to invade the arterial intima and contribute to the process of atherosclerosis, has an ApoB particle attached to it. You see the chylomicron remnants, which is code for triglyceride, VLDL, LDL, which is really our surrogate marker, and then Lp(a). These are all atherogenic lipoproteins. They all contribute to atherosclerosis. The only one that doesn't, which has an ApoB, is chylomicrons, and that's just because they're too big to invade the arterial wall. So each particle with an ApoB molecule on it contributes to the overall atherogenic risk. And so your overall risk is really calculated by the amount of individual ApoB containing lipoproteins that you have in the serum, not just LDL. We're talking about VLDL, chylomicrons, Lp(a), etc. So one thing we can do to better understand the risk that her LDL cholesterol poses is to get an LDL particle number. So like we said, the individual risk comes from the amount of lipoproteins that contain ApoB. And so when you're measuring LDL-C, it'll come to you in a mass. It's milligrams per deciliter. It's just a mass. And that mass can be a lot of few fluffy, big particles, or a lot of small, dense particles with a lot of ApoB. And so even with the face value of an LDL cholesterol of 100, you can have more ApoB versus less ApoB. The higher the particle number, the more ApoB there is, the more the atherogenic risk. Sometimes you'll see, and I didn't mention on the slide, a type A, which is a profile that's suggestive of large few cholesterol particles, versus a type B, which is more of a numerous small particle profile. If that ever comes across, that's kind of what that's pointing at. Large observational studies have suggested that LDL particle number is a better predictor of risk than LDL-C, because obviously we're looking at ApoB molecules. You can order a test. It's available on Cerner. It's called an NMR lipo profile, and this really digs into the details of your LDL cholesterol. And you can see down here in the graphs, you have a patient who has an LDL-C, for example, of 90. But when you calculate their LDL particle number, it looks like it's 1600, which is on the higher end. So what this is telling us that her LDL cholesterol, this patient, even though it's low 100s and her coronary calcium is 0 and her ACVD isn't elevated, her LDL cholesterol is at higher risk at face value than the LDL-C suggests to us, meaning that this is more atherogenic than our routine lab shows us. When we're looking to, without ordering the NMR lipo profile, ways to kind of assess what someone's ApoB is, we can look at something called non-HDL cholesterol, which is total cholesterol minus HDL-C. This is a rough estimate, or really, of our ApoB burden. And what that takes is numbers that are available on every lipid panel, and it's TC minus HDL-C. And so again, when compared to LDL cholesterol, non-HDL represents the amount of ApoB burden, but also is a better predictive of risk. So the question stands, why don't we just use ApoB and non-HDL routinely? Several post-hoc analyses of statin trials have suggested that ApoB is a better marker of cardiac risk and maybe a better target overall. And there's no data to suggest otherwise, but the biggest limitations with ApoB is that traditionally we just haven't used it in any statin trials or any algorithms for cardiovascular risk. And so it's hard to switch over from LDL-C to ApoB and have guidelines and goals when our nomenclature and units of measurement have always been LDL-C. And so in this patient, we can certainly use non-HDL cholesterol as a risk stratifier. Non-HDL cholesterol will estimate the amount of ApoB, the amount of particles, obviously, give us more information than just an LDL cholesterol levels. It can also, in a different patient population, give us secondary targets. Let's say we have a patient whose LDL cholesterol is 40, and he keeps having cardiovascular events. We've addressed his inflammatory profile. We don't know what else to do. Using ApoB or non-HDL-C as secondary targets can be a way to better augment this therapy. Today, guidelines don't really suggest a hard ApoB number to aim for or a non-HDL. Usually, it's a non-HDL 30 points above your LDL cholesterol goal. That's what the European guidelines have suggested, but hasn't truly been incorporated in any literature quite yet.
Yeah. Thanks, Ori. So non-HDL was in the guidelines quite a bit, but got demoted because it's not really part of the trials. But if you want to know atherogenic total risk, you just take that total cholesterol, subtract your HDL, and that's the number. But what's within that quite a bit is triglycerides. And so I want to go on to this case and really say, how are you focusing on triglycerides? So a 51-year-old female with diabetes and hypertension who's not had CVD yet, seeing in your afternoon clinic, pay attention to that detail. You treated her with a TORVA 40, and she's total cholesterol is 160, LDL is 74, HDL is 40, triglycerides are 116. And she's doing what she can do for exercise, diabetes well controlled. Her remnant cholesterol is 46. You're saying, what's remnant cholesterol? I've never even heard of that. So what would your response be to this? LDL 74, she's on a good dose of a statin, say, keep trucking, or what would you tell her about her triglycerides? Well, triglycerides matter, and for any level of risk, triglycerides are incremental. But here's a tip. You can't have people fast and measure triglycerides. You have to do non-fasting triglycerides. And I have an afternoon clinic, and I always surprise patients, and I say, on your way out, let's get a lipid profile. They go, but I ate. I'm like, perfect. And I hope you ate poorly, because I want to catch you. No, I want to see how they live. I'm going to show you how that is. And indeed, these are these data. These are from Women's Health Study. If you do fasting triglycerides, they do not predict events. If you do non-fasting triglycerides, they do. And it's the time from meal of about 2 to 4 hours that you really catch risk. So what's going on here? Well, triglycerides are two things. They're triglycerides made out of the liver in VLDL, and that's on the lipid profile. And then there are chylomicrons. This is the absorption form of cholesterol from the gut. They have a B48, not a B100. And then they are hydrolyzed using lipoprotein lipase to make these small things called remnant cholesterol. So your triglycerides rise because your chylomicrons rise, they get hydrolyzed, and you're left with these little things called remnant cholesterol, chylomicron remnants. Chylomicron remnants are highly inflammatory. They penetrate the vessel wall and they stimulate atherosclerosis. Chylomicrons don't. So I want to catch the people that have high triglycerides in the postprandial state, because those are folks that are having trouble managing, they're having high circulating levels of triglyceride-rich lipoproteins, which have ApoB, they're part of non-HDL, they're atherogenic. I want to see them. I don't want them to put plastic surgery on their lipid profile by fasting for 12 hours. We live in the postprandial state. Other when we're sleeping, we're pretty much eating. And so our triglycerides rise, and they rise, and they rise. We are postprandial all day long. So let's measure them in that state. And it's in this 2 to 4 hour range that triglycerides rise. LDL doesn't really change. We measure LDL in all labs in MedStar using direct LDL. It's not calculated from triglycerides. So in fact, the lipid profile, it doesn't affect LDL. Non-fasting doesn't affect LDL. It doesn't affect HDL. You simply see triglycerides where people are living. So you must be measuring triglycerides in the non-fasting state. In patients like that, they don't have to fast overnight to come to a visit. You calculate remnant cholesterol, remnant cholesterol, or remnant chylomicrons by just taking the total cholesterol and subtracting HDL and LDL. So whereas this is non-HDL, you take out the LDL fraction, and that is remnant cholesterol. And you can see that for any given level of remnant cholesterol that's above 19, risk is higher. So remnant cholesterol relates to risk, and remnant cholesterol are inflammatory and atherogenic triglyceride-rich lipoproteins that come from the delayed dietary metabolism of absorbed cholesterol. What do you do for this? Well, we've used over-the-counter fish oil, and meta-analyses such as this one show that over-the-counter fish oil is ineffective. It has two things in it. It has DHA and EPA, and they are different omega-3 fatty acids that have different effects. And the problem with over-the-counter fish oil is you don't know how much DHA and EPA is in it, and it's full of other stuff. So you have to use prescription fish oil, which these days is purified eicosapentaenoic acid. So there's the eicosapentaenoic acid and there's docosahexaenoic acid, EPA and DHA. They're both omega-3 fatty acids. They're both in fish oil. They're different. It's felt that EPA is more antioxidant and has more plaque stabilization properties to it than DHA. And EPA actually integrates within plaque and stabilizes and suppresses inflammation in plaque. And do different things. This is Lovaza, which is a prescription form of DHA and EPA. It lowers triglycerides, but it raises LDL a little bit while lowering non-HDL. Purified EPA here lowers triglycerides, but also lowers LDL and non-HDL. So there are different things that this does than this, but the bottom line is here. Purified EPA is proven in a randomized clinical trial of people with known heart disease or diabetics at risk when triglycerides are over 150 to profoundly lower cardiovascular events and lower total mortality. And this is after already being on a statin at high dose with well-controlled LDL, simply having triglycerides over 150. So the bottom line here is that while you have to think about triglycerides as atherogenic because they're part of non-HDL. It's the molecule that's causing, it's the molecule in VLDL and chylomicron remnants that's causing the particle problem. But you've got to treat it, and you've got to treat it with these days with prescription eicosapentaenoic acid. It's 2 grams BID, that's the dose, and it's highly effective. Economic analyses of this show that if you use this, it actually saves the health system money. It has a dominant economic analysis. It saves net money. So for this patient, I would convert her to Rasuva because LDL HDL ratio is still over 1.5. I'm going to measure a non-fasting lipid profile, and all my lipid profiles are non-fasting. I'm going to evaluate her triglycerides, calculate her remnants, and I'm going to treat her not with over-the-counter fish oil, but with purified EPA, 2 grams BID. Now, in our last patient in clinic today, this is a prevention poster boy. He's had an event, but he's on Rasuva 40. He's on a PCSK9 inhibitor. He's got an optimal LDL. His LDL HDL ratio is optimal. And he says, is there anything more you should be doing to prevent another MI? He shows you a lab report from an annual physical, and the CRP is 2.5. He's got that highlighted in yellow for you. And he shows you this news clipping. June 20th, 2023. FDA okays low-dose colchicine for broad cardiovascular indication. And in fact, 2 months ago, less than 2 months ago, the FDA approved colchicine for cardiovascular prevention. In fact, these are comments from one of the eminent, or probably the preeminent research physician in the country on inflammation and cardiovascular disease. And he writes, Paul Ridker, that this approval is a huge signal that physicians need to be aware of inflammation as a key player. And he pointed out the indication for this drug is very broad by the FDA, and that it can be used in adult patients with established ASCVD or multiple risk factors for cardiovascular disease. And he said it is virtually identical to the indication approved for statin therapy. So basically, if you're on a statin, you probably should be these days on colchicine. And I'll bet few in this room have used colchicine yet for cardiovascular disease. But the data has been coming for a number of years. For a long time, we've known that while LDL matters for events, lower LDL is better than high LDL. Lower CRP matters for events too. And it's an interaction. So CRP is an effect modifier for LDL. You want a low LDL and a low CRP. And at any given level of LDL, a higher CRP portends increased risk because you have more inflammation for that given burden of LDL. So CRP identifies risk. It's actually a stronger risk factor for cardiovascular disease than LDL. The odds ratios for high CRP are actually higher than LDL. So here's the premise. There's a lot of residual risk to cardiovascular disease. Even when you use all these new drugs, events are still happening. And colchicine basically is a broad anti-inflammatory that technically is binding tubulin, inhibiting tubulin polymerization. It preferentially accumulates in neutrophils and it suppresses the NRLP3 inflammasome, which basically in the vessel wall is turning off inflammation where it occurs at IL-1. It's a single dose of 0.5 milligrams of colchicine per day. And the reason the FDA approved 0.5 is because the dose reductions for renal disease are less than the 0.6 dose you use probably right now for gout. This is a new dosing of 0.5, and it's specific to cardiovascular disease. It's not the 0.6 that we've been using because that's all that's been available. 3 large-scale randomized trials in stable coronary disease, acute coronary syndromes, and patients with MI all showed benefit to events in a broad population of patients otherwise well-treated, with numbers needed to treat of 36, 30, and 63 comparing favorably to what statins do. And so in a meta-analysis, it simply drives home these points: 22% reduction for MI, 46% reduction for stroke, 23% reduction for coronary revascularization. No effect on cardiovascular death, however, in these trials because they were relatively short duration. There are ongoing trials looking at this further in other populations. And here's just a recent consult case. 80-year-old man with PAD, CAD, diabetes. He'd had PTAs, stents, brachytherapy. Ori's dad did brachytherapy to his LAD. He's on a Torva 80. He comes in with a non-STEMI. He's got progressive circumflex disease. So his LDL HDL ratio is 2. And even though he's on a Torva 80, he's still on fire inside because this ratio is too high. So the recommendations were he's extreme risk. Extreme risk guidelines now say that LDL should be below 40 in the current guidelines. So the goalposts are moving, guys. 55, 70 is the new 55. And if you're multiple events, your goal's actually in the guidelines 40. And so we recommended colchicine 0.6 milligrams renally adjusted to QO day. This is a couple of months ago before the 0.5 came out. So my response, I utilize the CRP to judge inflammatory risk. And this man, we started on colchicine, just like you do with a statin. So coming back to our learning objectives, and I hope you found this to be the best lecture on lipids you've ever had because you learned a ton of new stuff. And all we did was we dissected through the lipid profile on every patient and thought about each line individually. And we weren't mesmerized by the LDL. We're looking more broadly. So the take-home points are crush LDL. An LDL HDL ratio below 1.5 is the way you personalize care for your patients. Triglycerides are part of the atherogenic risk, and you've got to become comfortable looking at triglycerides and treating them. Applying the standard lipid profile, hopefully you'll use this to now use secondary LDL drugs. Use bempedoic acid, use a PCSK9 inhibitor. And we're making it easy in MedStar. We're putting in a standard Cerner pathway to help you order a PCSK9, and the specialty pharmacy will help you get it approved, because I know it's been hard. And lastly, it's time to get involved on the inflammation side, and don't be afraid of doing this. This is just like you use statins, as Paul Rieker says, you should be using colchicine. And again, it's secondary prevention. It's not primary prevention. So known events, but colchicine should be part of your armamentarium.